So, hello everyone. Welcome to Curbside to Bedside. This is Ryan. I'm here with Floyd.
Hello.
And today we are going to discuss my least favorite topic of medicine, which is DKA.
I think we've got some interesting points to bring up that is often overlooked. And it may not concern you a whole lot if you're, I think, primarily 911. If you do interfacility transfers, then this will be particularly useful for you. You get a relative or absolute insulin deficiency, which leads to hyperglycemia, which leads to dehydration, acidosis, and then a profound electrolyte imbalance per Rosen's emergency medicine. They kept it pretty simple too. So once the blood glucose increases, all of that glucose spills over into urine. That pulls water and a bunch of other electrolytes out. It pulls sodium, calcium, magnesium, phosphorus is a big one, but namely it also pulls potassium out. So you get massive electrolyte shifts from severe hyperglycemia. So you get a lot of diuresis. A lot of that is spilling over into the urine, causing the patient to urinate, and then they also present with poor intake and vomiting, and a combination of all of that leads to profound dehydration and subsequently electrolyte imbalance.
Yeah, that sounds good. I think namely of the two electrolytes to be most concerned about, the potassium most cardinally, and then is it erroneous to think that the sodium's probably not a bad one to watch as well?
Yeah, the sodium would be extremely important, and we'll talk about it later, but it can also help you differentiate between HHS and just regular old DKA. You may hear a little feet pitter-pattering in the background because I have 3 dogs in the room with us.
Yeah, I have 2 horses at my feet right now.
But when the patient becomes acidotic, they try to increase their overall minute volume, and your minute volume is your respiratory rate times your tidal volume. And the whole goal is to get rid of excess acid. And in the process, the patient uses up bicarbonate. All right, so generally you get metabolic acidosis with DKA, which is determined by the low bicarbonate levels. But patients may not present with acidosis. They can present with alkalosis if there's also concomitant vomiting, if they're vomiting out the acidic stomach contents. But your typical DKA patient presents with increased minute volume and low bicarb. And then obviously if they're in DKA, then they'll have increased ketone levels. Etiology. Ryan, what is the etiology of DKA generally?
So typically it's inadequate insulin administration, at least in your adult patients. Infection, MI, any sort of systemic stress on the body can trigger DKA. This is especially true with undiagnosed adolescents who typically have a sickness, fever, infection, something of that nature right before or following their presentation, right before their presentation with DKA. And it can occur in type 2 diabetics with only one type of stress, such as sepsis or a GI bleed. So basically anything that places a metabolic demand on the body or an increased metabolic demand on the body at a systemic level can trigger DKA. Now, I don't think like strenuous exercise would do it, but definitely something like shock state from sepsis or a hemorrhagic shock state from a GI bleed is typically enough to trigger it. And that's more classically.
And I think in like the type 2 diabetic, it would be odd for them to present with DKA without a stressful event such as sepsis or GI bleed. What we need to look out for in the history, I call it the 3 Ps: polydipsia, polyurea, and polyphagia. So they'll have weakness, weight loss, nausea, vomiting, and abdominal pain. So in children, abdominal pain is the norm. 1/2 of children report abdominal pain. This is frequently idiopathic, but in adults, if they have abdominal pain, then you should perform a thorough abdominal assessment because there's a good chance that there's an abdominal pathology that precipitated or caused the DKA.
All right, as part of your physical exam, you can observe Kussmaul's respirations, which are some of my favorite. This is where end-tidal CO2 monitoring comes in handy. Speaking of that, you'll often get low end-tidal CO2 readings with DKA patients as well. They'll be profoundly tachypnic and have that Kussmaul's respiratory pattern, in addition with hypocapnia. They'll also have a systemically decreased sensorium. Typically, they're tachycardic and hypotensive. Now, they may not be frankly or floridly hypotensive. They may just have a soft blood pressure. The tachycardia and hypotension is typically secondary to hypovolemia from that polyurea.
Correct. And so the interesting part I think about, well, I want to say something about two parts of the physical exam that you mentioned. One, Kussmaul's respiration. So I'm sure you're familiar with this pattern, deep, rapid respirations.
These people have very high minute volumes too, and they're getting in almost inspiratory reserve capacity type breaths, like deep, deep tidal breaths, and it's very obvious. That's one of the across the room censures for me for someone being in DKA.
Yeah, and so they are compensating. And if you were to switch them from this negative pressure breath physiology to a positive pressure breath, i.e. from intubating them, then you probably could not compensate as adequately as they are compensating. And so the spontaneous breathing is augmenting the patient's blood pressure and cardiac output. And there's a huge debate on, if you've got a patient in DKA with altered mental status, decreased sensorium, maybe they've vomited a little bit, should we take over the airway? And I think universally the answer is almost always no, because the patient is compensating. Now, if they're getting fatigued or they're at risk for
aspiration.
If they're at risk for aspiration,
I can't talk, but at least I can vocabulary.
Then you may need to consider it. But if you do decide to take over the airway, it would need to be from a skilled intubator, someone who can increase the chance of first pass success and decrease the chance of hypoxia and hypotension. And there are a lot of different methods to maintaining adequate ventilation during the pre-induction, induction, and the apnea period. And we'll link to that, some MCRIT references. But needless to say, once the patient is intubated, you most certainly have to maintain that compensation, which could mean having matching the respiratory rate at least 30 or higher. It would be good if you could get an end-tidal CO2 before the patient was intubated and try to match that. But if you're doing an interfacility transfer, they may have intubated the patient and you may walk in and find that the initial arterial CO2 was in the teens or low 20s, and now they've dropped their rate to 10, which sometimes they routinely do, drop the rate to 10 with a tidal volume of 500, and they've got a minute volume of 5 liters a minute when the patient probably needs like 10 liters a minute.
So it's not going to cut it. So the minute ventilation is really what helps these folks out. And when you convert from that negative pressure to that positive pressure, like Floyd said earlier, you kind of wreck their ability to compensate in many ways. Namely their acid base, but also that interthoracic negative pressure pump that kind of assists the cardiovascular system in compensating for that hypovolemic state.
And I think, so a good rule of thumb is if you don't know what rate to set them at on the ventilator, it's good to start them at 30. When it comes to decreased sensorium, so interestingly, patients with HHS frequently present with focal neurological symptoms as opposed to DKA. And when it comes to fruity breath, that has been perpetuated down, I think, from paramedic to paramedic.
I'm pretty sure Moses came up with it first and just handed it down from the mountaintop.
But it may or may not be present. So the absence or presence is not like a red herring. It's not something you can
correct me
depend upon.
If I'm wrong here too. I may be completely pulling this out of my ass. I think there's a certain percentage of the population that actually can't smell the ketones.
I'm not sure.
I'd have to go back and look that up because I'm pretty sure I'm one of them because I've never been able to get that. To the point where it's like, okay, this is going to be kind of weird. Can I smell your breath? Just a little bit. Not in a creepy way.
Yeah, I have smelled the fruity odor, but I can't remember the last time. But I do know that I have. It's not something that
I've had many a confirmed DKA patient and literally have never smelled it. Everyone around me has, but I haven't been able to do it yet.
But so that brings us to another good point. So let's move on to the labs. I think that we should do this more often when we're doing an interfacility transfer. It's especially important to look at the labs of a patient with a high blood glucose. It can help you differentiate between DKA and HHS, but there are other good findings that are clinically relevant. So when it comes to differentiating between DKA and HHS, in DKA, the glucose is generally greater than 350. In HHS, it's much higher, usually above 700. A few interesting electrolyte variations is that in DKA, the potassium is generally around 4.5 to 6. In HHS, it's somewhere around 5. So that could go either way. But in DKA, the bicarbonate is usually less than 10. It's in the name, DKA, Diabetic Ketoacidosis. And in HHS, it's usually greater than 15 because the patient doesn't have the ketoacidosis. Therefore, when measuring serum ketones in DKA, serum ketones are present. In HHS, they're generally absent.
Now, what about the pH?
So a patient is generally acidotic. We expect the pH to be low, hovering around, I think, somewhere around 7. But again, concomitant vomiting in rare cases can cause metabolic acidosis. So there are cases of patients with DKA to be on the alkalotic side of the pH. So just an interesting tidbit. It's really important that you measure potassium levels. Now, if you have a patient DKA, it's still important that you get a 12 lead because if you can't monitor potassium levels, an EKG may be helpful because the patient's going to have a potassium shift, even though they're going to have a severe potassium deficit of several hundred milliequivalents due to these potassium shifts. But due to the potassium shifts and the acidosis, it's normal for there to be if this is an accurate term, falsely elevated potassium because it shifts.
It's like a pseudo hyper K because it's So we all know that potassium is mainly an intracellular ion, and we measure most of our lab values from a serum concentration. So when these potassium shifts happen, they go from inside the cell to outside the cell. So you'll get a serum hyperkalemia when in fact the patient is intracellularly, where we really care about it, hypokalemic. So they do actually, even though they may be hyper K on your lab readout, they may actually end up needing potassium replacement therapy due to the profound intracellular hypokalemia.
Yeah, they will most likely, almost certainly need the administration of potassium, but they can present with EKG changes indicative of severe hyperkalemia, and the patient would still need to be managed for severe hyperkalemia, especially if they are unstable, and we'll get into that. And the patient is also extremely dehydrated. Their levels are going to be falsely elevated because their blood's going to be hemoconcentrated.
So in broad strokes, we're going to speak about the management of DKA, and there's some fairly general steps you can follow. Now, if you do primarily or only 911 response, toying with the insulin might not be in your wheelhouse necessarily, but there's a large body of EMS providers who do conduct interfacility transports and will routinely have insulin infused into their patient. So for the insulin, generally if the potassium is greater than or equal to 3.3 milliequivalents per a liter, then your insulin infusion is going to start at 0.1 units per kilogram per hour. Now, when the patient's glucose starts to be in a more controlled range, so less than or equal to about 300 milligrams per deciliter, you can actually change your IV solution to D5W and half normal saline. Routinely, normal saline is used for the fluid resuscitation of DKA patients. Lactated ringers may be preferred due to the amount of acidosis this patient already presents in, or another balanced solution like Plasmolite. Typically, you're going to have about 1 to 2 liters of normal saline infused within the first 3 hours. And that's generally your first step, is to start with that fluid resuscitation, because as we've said, these patients are often profoundly hypovolemic, and they may present in a hypovolemic shock or near to it. In children, you follow a fairly standard 20 milliliter per kilogram normal saline bolus during the first hour. So for the potassium, we need to ensure that the patient has adequate renal function. One of the ways we can do that is adequately fluid resuscitate. So you want to add 20 to 40 milliequivalents of potassium to each liter if your potassium is less than 5.3. We're going to go over in the broadest strokes possible potassium repletion in DKA. For the potassium specifically, if the potassium is less than 5.3, you can add 20 to 40 milliequivalents of potassium to each liter of volume that's given until the acidosis is corrected and the pH normalizes, because that's the main driving force of that potassium shift from the cells into the interstitium, or into the vascular space, into the serum.
So if you don't add that potassium on and the potassium is less than 5.3, as you correct the acidosis with volume repletion and insulin administration, then that potassium is going to shift back in the cells and drop precipitously, and then you're going to have a hypokalemic cardiac arrest. Something we frequently don't do in our facility is, hey, I've got a patient on insulin. Sure, I asked them what the blood glucose is, but I paid no mind to the potassium, and that is bad. Yeah, and when it comes to administering potassium, the range is anywhere from 20 to 40 MEQs in each liter. But I think they generally try to shy away from higher doses unless you have something like a central line. But, Ryan, I think that when it comes to getting the insulin dose correct, getting all of this correct, you're going to need to pull out your phone, pull up the protocol, pull up the algorithm for the management of DK or HHS, because there's quite a bit to it, right? And
yeah, it's not necessarily a simple process.
When it comes to administering insulin, so the dosing is pretty well established. However, you may find some old souls out there that want to bolus insulin before starting the infusion. Now, that might be okay, I think, if it's going to take a while for them to actually get the IV insulin on board. However, there's generally no need for a bolus. Low and slow is the recommended approach right now. And when it comes to transporting insulin, we have to remember that insulin does bind to IV tubing. Now, the nurses should know this and flush the line with a few cc's, somewhere around like 10 to 50. A lot of institutional protocols have protocols to flush it with 50 cc's of insulin, so that that all of the spots will be bound and that they'll actually get the concentration of insulin, or at least most of what they need. But I know if you're doing an interfacility transfer or a flight, some people would prefer to just put an extension set, like a half set, onto the end. And when you do that,
which in ours is an extra 20 milliliters of tubing.
Yeah, it's a lot. So, and generally,
it's quite a bit.
They mix the insulin in, I think, 100 ml bags. Mm-hmm. So the whole bag's pretty much going to be gone by the time you do that. But you're going to have more of that insulin binding to the new IV tubing. So it would be best probably just to get a new bag, I would say, and start the infusion over at that point. So with children, we don't want to specifically talk much about children. We may have a podcast on that.
That's kind of another one in its own right in my mind.
Yeah. So in children, it's kind of controversial. They want you to avoid higher doses of insulin and very large fluid boluses in kids because they are reported to be at greater risk for cerebral edema. But with kids, it's definitely important to remember that when the blood glucose is 250 to 300, that you add dextrose because this helps prevent cerebral edema, and they're at greater risk of developing cerebral edema when the blood glucose is about to normalize. So you most certainly want to get that dextrose on board.
As we've kept hammering home, these patients are profoundly dehydrated typically when they get to us, and they can have a fluid deficit of anywhere between 3 to 5 liters fairly commonly. If you think about that, that's a hell of a lot of water to lose. If the adult patient presents in shock, you can administer fluid at the 20 milliliter per kilogram range as rapidly as you can until the systolic is about 80. Granted, use your common sense. Don't give someone, flash pulmonary edema or anything like that. You don't have to hook up 4 level 1s to this person. A rapid fluid bolus is probably warranted in these patients, especially if they're approaching extremis. And the fluid resuscitation alone as a secondary point might also help lower the blood glucose level. And this is due to decreased levels of circulating insulin that may be present. An increased perfusion may transport insulin to previously untapped receptor sites. You give that hemoconcentration, insulin in the hemoconcentrated serum, a little bit of more of a highway to find other insulin binding sites and thus lower the blood glucose that way. And you may get a very small effect of blood glucose lowering by dilution. I don't know if you've heard that urban legend, Floyd. The primary reason we give fluid in DKA patients is because it dilutes the amount of glucose, which is, as I understand it, not entirely the case.
No, I've heard that too.
That's a fairly common one.
Yeah, it's not real. I mean, it might be true, but the actual reason is because you're just helping perfusion. You're reducing the acidosis, and you're helping facilitate transport of insulin to the cells. I think that's the main reason. And Rosen said that the mean plasma glucose concentration has been dropped 18% after saline administration without insulin.
So it's like your own endogenous little insulin bolus that you can kind of help them along with.
Yeah. It's controversial whether or not you should start a fluid bolus before you start insulin. But I think the key point is that, if the patient's in shock, you're going to need that fluid bolus, right, to help resuscitate them. And it's probably more important that you obtain potassium levels before you administer any insulin. Now, in closing, this is very controversial, and I think in the social media, the FOMED world, it's not that controversial. Everyone pretty much unanimously agrees that bicarbonate is bad, that you really don't need to administer bicarb, much if at all, in a patient with DKA. But I think that the DKA guidelines still recommend it if they're severely acidotic, if the pH is less than 6.9, and if they have...
Which is basically not compatible with life. It's a kitchen sink maneuver.
6.9 in a DKA. Olympic rowers, I heard Cliff Reed say that Olympic rowers drop their pHs into the high 6s.
No joke.
Yeah. But I mean, different pathology. Different pathology, I guess. I think the guidelines only recommend the administration bicarb if the pH is like less than 6.9, the patient's unstable, peri-rest, has some myocardial depression, because one, bicarb does drive potassium into the cells. So the addition of the bicarb and the insulin can make hypokalemia more likely. And also, when you administer bicarb, that could suppress the patient's hyperventilation or hyperventilatory response by increasing the CO2 levels. So something to think about. I wanted to add something to this podcast because we had it peer reviewed by our physician friend, Walt Lubbers. and I think he had a few pearls that would be important for us to cover. And I'm going to be quoting him a lot, maybe paraphrasing a few things. He says that giving fluid is super important. A bolus of 1 to 2 liters, followed by putting them on a rate of 1.5 times the maintenance, is a pretty safe way to start, and pound for pound about the best thing you can do. If you can do one thing, it's give them fluid. Giving the patient glucose instead of turning off the insulin when the sugar drops is kind of confusing to people, but it's really important to hammer that in. Don't stop the insulin. Even if the glucose is better, the insulin is there to correct the bad stuff that's going on otherwise. The problem is not so much the elevated glucose. The problem is the body's inability to use the glucose it has. The osmotic diuresis does some bad stuff, but once you replete the fluid deficit, the simple presence of the glucose isn't that big a deal anymore. But the fact that you are still unable to use glucose and still making ketones is the bad thing. So you keep the insulin going until the ketones have cleared, signaling metabolism has been restored, the acidosis has resolved, and the anion gap has closed. If you turn off the insulin without giving it in some other way like sub-Q, you are just letting them start to produce ketones again and setting them back because they still don't have adequate insulin to get the glucose into their cells. It's equivalent to throwing a drowning man a life preserver, then pulling it away once he catches it because his oxygen sat is okay. He still has the same primary problem, so don't turn off the insulin outside the hospital. You can turn it down a touch if you just can't maintain the glucose, or you can give more glucose but don't turn it off. FYI, while IV insulin is often used, there's something to be said in many adults for doing just fluid replacement, electrolyte repletion, and giving sub-Q insulin and avoiding the drip altogether. In reference to potassium replacement, to make it easy, don't give insulin until you know the potassium. If the potassium is elevated, give insulin and IV fluids. If potassium is normal, give potassium, IV fluids, and insulin. If the potassium is measured low, don't give insulin. Give IV fluids and potassium until the potassium is normal and then give insulin. One other thing on the potassium. Resist the temptation and don't treat it if it's high. It may be high, but you're going to give them fluids, insulin, and glucose, correct their acidosis in just a minute. Don't be in a super big rush to give them something for their elevated potassium specifically. If they're unstable and bradycardic with wide QRS complexes, then give them some calcium while you're getting the fluid and insulin ready, but don't panic if they have an elevated potassium. If they have a little peak T wave, you're going to fix that in a minute. They either get calcium for their wide QRS complex, or you forget about the elevated potassium for now and watch it resolve as you treat everything else. For your information on cerebral edema, probably happens when we try to fix stuff too fast. If your shriveled up brain all of a sudden gets tossed in a bunch of free water and you drop the glucose concentration from syrup down to crystal light, the brain soaks up all that free water and it does so really fast. There's probably a large proportion of kids, especially who get a subclinical amount of cerebral edema with correction even at moderate speed. And that was his input, and I want to just thank Dr. Lebers for being a peer reviewer on this podcast. And I think that's all I have, Ryan.
That's all I have, for sure.
Well, we hope that you enjoyed this podcast, and as always, if you have any questions, you can email us at curvetobed@gmail.com. Twitter is @curvetobed, and I think Facebook is also @curvetobed. Oh, yes, and we are also on Instagram.
We are.
Although we're not as active. But all right, that's it for now. Bye.
Bye.